Our next presentation is S068, Raising the Quality of Hernia Care, Is There a Need? To be presented by Dr. Zahiri.
Thank you very much. I'd like to start by thanking the SAGES Committee and the session chairs for the honor of the podium this afternoon. The title of our talk is Raising the Quality of Hernia Care, Is There a Need? Do not have any relevant disclosures. Ventral, incisional, and inguinal hernias continue to be some of the most common diseases that are faced by general surgeons, with 800,000 inguinal hernia repairs and an additional 400,000 ventral/incisional hernia repairs that are performed in the United States annually. The combined yearly economic impact of hernia disease has been estimated to be about $45 billion yearly. Now, despite our extensive experience with hernia repairs, as well as the evolutions that have taken place in the care of hernia patients, current hernia care continues to suffer from some major deficits. And these include high recurrence rates, non-standardized approaches, inadequate surgeon training, lack of long-term patient follow-up, as well as paucity of federal research funding. Recognizing these deficits, SAGES formed a hernia task force in 2011, charged with development of a comprehensive, flexible, cutting-edge hernia education program to help improve outcomes for our patients after hernia repairs. In order for the hernia task force to accomplish their objectives, they designed a needs assessment study to engage all key stakeholders involved in the cycle of care of hernia patients in order to be able to accurately assess the current state of hernia disease, current deficits in care, as well as if there is a need for additional hernia education for surgeons. They conducted a survey study reaching out to 20,000 members of organizations such as SAGES, as well as American College of Surgeons and others, and their targeted response rate was 2% or 400 respondents. To their delight, the response rate was actually double that, and there was good representation from all key stakeholder groups. The first group, the most important group, our patients, were actually surprisingly quite satisfied with their hernia repair. In fact, 85% stated that they would go back to their original surgeon for any additional care. However, when they were asked what two factors they used to choose their surgeon, the top two factors were referral, number one, and the surgeon's personality, number two. When they were asked if they thought additional hernia education training was important for surgeons and would help them, the vast majority did not think that it would. Now, this is in stark contrast to surgeons who participated, with the vast majority stating that they thought hernia recurrence rates were at least 25%, almost 1/3 of whom also related applying the same limited range of repair techniques broadly to patients. And with respect to long-term patient follow-up, only 45% related that they or their organizations engaged in such efforts. Now, when surgeons were asked what they thought was the most important factor leading to poor outcomes after hernia repair, surgeons blamed surgeons. They stated that inadequate training, poor technique, lack of long-term follow-up were more important than patient factors. Furthermore, surgeons almost overwhelmingly agreed that a comprehensive, tailored, multimodal, standardized, flexible hernia education program was needed, with emphasis on the basic and advanced techniques of hernia repair, patient outcomes, and pre- and intraoperative decision-making. Now, the remainder of the stakeholders were grouped together, and this includes nursing, hospital administrators, health payers, and others. And the reason for that is because their responses were similar. In contrast to surgeons, when these groups were asked what they thought constituted or was responsible for the poor outcomes after hernia repair, they thought patient factors such as biology, comorbidities, and compliance were more important than surgeon factors. However, consensus was found when these groups were asked what they thought would help improve hernia care, citing, number one, more surgeon education and training. They also stated standardization of hernia care practices, as well as better communication between nurses and surgeons in the operating room. So what can we conclude from these findings? Well, foremost, that the 360-degree perspective on hernia disease adds value, not only by considering the unique perspective of all key stakeholders involved in the care of these patients, but by looking for the common thread, which can then be used to design viable strategies to help improve outcomes for our patients after hernia repairs. According to the 360-degree perspective, the vast majority of stakeholders, with the exception of patients, felt that more hernia educationist training is needed for surgeons. And furthermore, they felt that the most effective education model would be one that would be geared toward adult learning styles, would be tailored to the specific needs of each surgeon, would be flexible, would be cutting edge, incorporating simulation as well as web-based learning, and multimodal, still incorporating traditional learning such as didactics. In closing, I'd like to thank my chairman, Dr. Adrian Park, my mentor, as well as the remainder of the hernia task force members for graciously letting me be part of this project. Thank you.
So thank you. This is now open for discussion. You've clearly identified that surgeons are clamoring for a new hernia education product. There are, industry-driven courses, there are society-based courses. So what's the plan moving forward that's going to be different than the educational opportunities that are already available?
That's a great question. Thank you very much. Actually, there's been a tremendous amount of effort in the last 20 years by surgeons as well as industry supporting surgeons to try to get a comprehensive educational hernia education program going. The problem is that it has not been unanimously or at least overwhelmingly embraced. The participation by surgeons has been kind of on and off depending on the region as well as the particular course that's being offered. And so I think going forth, according to what we found out in this study, we need to devise or design a program that is really engaging to surgeons. I'm not sure that that has been consistently done to the point that has encouraged or motivated surgeons to give up additional time to do that. So I think some of those, I know certainly are general at this point, but some of these characteristics of being geared towards adult learners, being flexible. If a surgeon, for example, prefers to do more simulation as part of their training, as opposed to, let's say, to another surgeon who would rather do more web-based learning, we have to be able to make that available to them and also make it standardized so that we as an organization, as a group of surgeons nationally, support one hernia education that we think would be beneficial to all of our members.
Dr. Fried?
If I could, Jerry Fried from Montreal, I just wanted to follow up on the last question. Did you specifically ask in your questionnaire whether this, particularly to the surgeons, whether they've had any formal educational experiences with respect to hernia, and what the gap was in that instructional design? So,
right.
You had a list of different qualities what you felt would be a good educational tool.
Right.
Was that based on the fact, okay, I took a hands-on course, but it just ended there? Like, right. What we really want to get an understanding of is what can we do differently, and how have the previous efforts failed, because there's so many of them out there?
Absolutely. No, thank you. That's a great question. So, yes, they were engaged specifically about what their hernia experience has been. So our group of surgeons, just focusing on that stakeholder group for now, we had HTF members, hernia task force members, which was about 18 members who participated. And the remainder of surgeons were community and academic surgeons. Now, the HTF surgeons were almost unanimously had academic appointments. On average, they had 15 years of experience as attendings dealing with hernia repairs. That experience was similar, actually, on the non-HTF surgeons, about 50% community, 50% academic, as well as about 15 years of practice experience with about 10 to 15 hernia patients monthly. That was what was related. Now, this was a survey study, and certainly the people could have commentary. There were some people that commented on specific courses that they had engaged in, but ultimately what the consensus was whatever participation that they had engaged in terms of courses had not traditionally met their needs adequately, and that they were in fact looking to different places and different sources, looking for that one source that kind of brought everything and everyone together, and that's where it was lacking. So those characteristics that I had listed were, per word, what a lot of the surgeons that had essentially stated going through their surveys and responding in terms of what would be the ideal program that would help engage them and kind of begin us on this path of bringing everyone together to devise, I guess I'll call it a universal resource for surgeons.
Thank you.
Thank you.